Assalamu alaikum. Oral necrotizing sialometaplasia is a benign, self-limiting condition affecting minor salivary glands in the oral cavity that presents like a big necrotic single ulcer that can be easily misdiagnosed as either squamous cell carcinoma or mucoepidermoid carcinoma. Necrotizing sialometaplasia is a reactive necrotizing process that is quite uncommon. It amounts to about 0.03% of all the oral lesions biopsies. It affects most frequently the minor salivary glands, particularly in the posterior part of the hard palate, but it can affect the minor salivary glands or indeed any mucinous glands in the mucous membrane of the oral cavity and the upper aerodigestive tract. It can also affect the major salivary glands. It has clinical and histological similarities to malignant lesions, and this implies a risk of unnecessary treatment or mistreatment. Oral surgeons, ENT surgeons, and dental surgeons should be aware of this lesion so as to avoid errors in the diagnosis and the treatment of this benign condition. Necrotizing sialometaplasia was first reported by Abrams in 1973. It's classified by the WHO under the group of tumour-like lesions of salivary glands. These lesions are benign but relatively rare. They may be confused with malignant lesions, both histopathologically and clinically, particularly squamous cell carcinoma and the mucoepidermoid carcinoma. The condition is uncommon and it is benign, but it has a diagnostic significance in that its clinical and histopathological resemblance to carcinoma can lead to mistreatment. The histological features of sialometaplasia include acinar cell atrophy and necrosis and squamous metaplasia of the duct epithelium underneath ulcerated surface in the submucosa. This requires a higher index of suspicion and good communication between clinicians and pathologists to reach a correct diagnosis and prevent unnecessary surgical therapy. It affects mainly the posterior part of the hard palate, but it can also affect other sites in the upper aerodigestive tract, including the major salivary glands, the nasal cavity, trachea, larynx, buccal mucosa, the maxillary sinus, the tongue, the tonsil, and the retromolar trigons. Up to 10% of the cases have been reported in the major salivary glands, and when this lesion affects other sites like the lung or the breast, it's usually called syringometaplasia or adenometaplasia. It can also affect the skin, where it would be referred to as a green squamous syringometaplasia. And if this happens in the reports of skin necrotizing sialometaplasia, it's usually reported in association with chronic ulcers, cytomegalovirus, herpes virus, underlying neoplasia, or after chemotherapy. The etiology is vascular ischemia that causes necrosis of the area. This can follow physical, chemical, or even biological injury to the vascular supply of the area. Physical in the form of surgery or dental work or ill-fitting dental prosthesis or radiation, or chemical in the form of acid irritation from in bulimic patients who have self-induced vomiting with repeated exposure to the gastric acids, or biologic in the form of certain inflammatory processes. Smokers have higher prevalence of palatal lesions than non-smokers. The reason why most lesions develop in the posterior part of the hard palate is perhaps related to the palate being more sensitive to ischemia than other areas in the oral cavity. The pathogenesis starts with the ischemic injury. Subsequently, there will be attempts at regeneration, and this can induce epithelial metaplasia and other pathological features. There will be 5 different histological stages in the development and the pathogenesis of sialometaplasia, starting with the infarction, followed by sequestration of the infarct area, ulceration, and then attempts at repair and ultimately the healing. These stages could overlap and would be dependent upon the extent and the severity of the damage to the vascular supply. And these are the commonest causes of physical, chemical, or biological injury to the vascular supply of the oral cavity mucosa, particularly the palate, that may produce the sialometaplasia. Top of the list will be surgical procedures, including injection of local anesthetics, dental injections, and blunt force trauma, the wearing of dentures, particularly ill-fitting dentures, violent or induced vomiting, like in bulimia patients, sometimes other environmental factors like pollution or tobacco use or cocaine due to its constrictor effects can cause the injury. Upper respiratory tract infections or sickle cell disease have also been implicated. Reported cases in the trachea had followed intubation, and similarly was also described in the larynx following endolaryngeal intubation. The necrotizing sialometaplasia usually present as a single ulcer in the oral cavity. It can sometimes, but not very often, has general systemic features such as pyrexia, chills, and malaise. Despite the extensive area of the ulceration, there is rare bony involvement of the hard palate or other bony structures in the oral cavity. There have been rare reports of upper airway obstruction due to the lesion and the swelling around the lesion, and very rare reports about excessive bleeding leading to hypovolemic shock in some cases. The initial presentation would be of a tender erythematous nodule on the posterior part of the hard palate or at the junction between the hard and the soft palates. And this erythematous nodule would then ulcerate to produce a deep unilateral ulcer with a yellowish base. So it will end up with an acute and solitary painful oral ulcer. Usually affects middle-aged men in their fourth decade. The mean age is about 45 years. There is a male predilection about 2-to-1. The ulcer has a crater-like appearance, and 75% of the lesion would be in the posterior part of the palate, but it can also affect the lower lips, the retromolar area, sublingual area, the tongue, and the larynx. The size of the ulcer can be big. It ranges from 1 to up to 5 centimeters. Attempts at healing will be evident after a week or 10 days, and the ultimate healing may take up to 7 weeks, usually about 6 weeks for the whole process of the self-limiting healing of the sialometaplasia. So the classic presentation would be of a single unilateral ulcer of the posterior part of the palate with a clearly circumscribed edge and yellowish base. The ulcer would be painful, but there would be other atypical forms. In 10% of the cases, it can be bilateral. The presentation can be of bilateral ulcers. In 15% of the cases, there may be no pain. It would be asymptomatic. And in some cases, there would be no ulcer at all. The lesion would be just a raised nodule that is also fluctuant, resembling more an abscess rather than an ulcer. The top of the list for differential diagnosis includes the squamous cell carcinoma and the mucoepidermoid carcinoma, and perhaps also non-Hodgkin's lymphoma. I will go through the pathological features that distinguish these tumors from sialometaplasia. The other differential diagnoses include nicotinic stomatitis, which is a non-neoplastic, non-pre-neoplastic or pre-malignant lesion. It affects primarily smokers of cigar and pipe smoking, like multiple foci of keratinization or thickening of the oral cavity epithelium, particularly in the palate, that can resolve completely upon cessation of the smoking. There is another condition, the subacute necrotizing sialodenitis. This is a quite rare condition that have some similarity with sialometaplasia. We'll discuss this at the end of the presentation, but basically it affects a younger age group, and it forms a painful mass rather than an ulcer on the palate, and it self-resolves much more quicker than the sialometaplasia. A comprehensive review of more than 180 cases of sialometaplasia showed the characteristic pathological features. The size of the lesion is just less, the average size is just less than 2 centimeters, and it ranges from less than 1 centimeter up to 5 centimeters. The pathological features include this, the ulceration, and just adjacent to the ulcer area there will be this pseudoepitheliomatous hyperplasia of the adjacent mucosa. There will be this area of coagulative necrosis of the minor salivary glands, with extensive leak of the mucin outside the necrotic acini, a varying degree of fibrosis because of this, including inflammatory cells and also fibrosis, and an islands of squamous metaplasia of the ducto-acinar units. These are the distinguishing features. But the most important distinguishing feature is this, the maintenance of the salivary lobular architectures despite the coagulative necrosis. You could see the surface ulceration, you could see the pseudoepitheliomatous hyperplasia, you could see the islands, the submucosal islands of the metaplasia, tubular cell metaplasia, and also the varying degree of fibrosis due to the leak of the mucin into the submucosal tissue. On the use of higher magnification in the submucosal area, the atrophy of the acinar structures will be evident, together with these epithelial nests in the submucosa formed of the squamous metaplasia of the residual salivary ducts. It's these epithelial nests that resembles a sinister pathology of a tumor, particularly if there is any associated atypia of these metaplastic cells. The key distinguishing features of sialometaplasia from malignant lesions is the maintenance of the lobular architecture of the lesion despite extensive squamous metaplasia. Despite the necrosis and the metaplasia, the architecture of the salivary glands, the minor salivary gland here, is maintained. This may not be very evident in very small biopsies, so the biopsies may need to be repeated for this reason. If there is difficulty in the differentiation, immunohistochemistry can be useful. The squamous cell carcinoma would be positive for things like P53, Ki67, and BCL2, whereas the sialometaplasia would not. And now the management of necrotizing sialometaplasia. The ultimate goal in the management is to avoid over-treatment of a self-healing and benign condition. The lesion would be expected to regress on its own on the removal of the predisposing factor. The lesion would spontaneously heal within 2 to 3 months. The necrotizing sialometaplasia does not usually recur, so that's reassuring. So if it is properly diagnosed, then surgical excision is not necessary. The lesion that failed to resolve within 2 to 3 months after controlling of the predisposing factor may need to be reassessed and biopsied. Otherwise, the treatment during the healing phase should be just symptomatic. The symptomatic management of necrotizing sialometaplasia is based on pain control, either by systemic medications or local applications, and also the antiseptic management of the ulceration, things like chlorhexidine gel or different mouthwashes and gels to prevent secondary infection of the ulcer. These are the basis for the symptomatic treatment. Biopsy may be indicated to rule out a malignancy if there is no signs of any attempt at healing after a few weeks, or local debridement of the ulcer may be required if there is extensive ulceration process to accelerate the healing process. The medications and the agents used in the symptoms relief include saline mouthwash, topical analgesics and anti-inflammatory like benzidamine mouthwash or spray, antimicrobial agents such as chlorhexidine mouthwash, spray or gel. Barrier paste can be applied to the ulcer to prevent secondary infection and relieve some of the pain in the form of caramellose gelatin. Topical anesthetics such as lidocaine, either spray or ointment, and also systemic analgesics can be used. In addition, patients will need to reduce or stop the tobacco, alcohol, or spicy consumption, together with also reducing the acidic food and drinks, and control of conditions that predispose to sialometaplasia like bulimia nervosa. And finally, we reach this condition of subacute necrotizing sialodenitis, SANS, which has several clinical and pathological features shared with the necrotizing sialometaplasia. This condition of subacute necrotizing sialodenitis remains of idiopathic etiology. It's a reactive process affecting mainly the minor salivary glands. It affects patients at a younger age in their second decade, in contrast to sialometaplasia affecting patients in their fourth decade. It presents with a painful mass in the palate, but it is not ulcerated in contrast to sialometaplasia. The male predominance is more pronounced in the SANS condition. It's almost 3-to-1 males to females, but this may reflect a sampling bias because some of the reports were obtained about this condition came from military barracks. The pathological features of subacute necrotizing sialodenitis is that of a non-ulcerated submucosal masses in the oral cavity, particularly the palate, ranging from 3 mm to about 2.5 centimeters. The histological criteria are that of acinar cell necrosis and a mixed inflammatory infiltration. So it's basically necrosis of the acini and a mixed inflammatory infiltrate, including neutrophils, eosinophils, and plasma cells. In contrast to sialometaplasia, it does not show ulceration. It is submucosal mass rather than ulceration, and there is no metaplasia, and there is no signs of fibrosis in the submucosal area. The ultrastructure pathology of the subacute necrotizing sialodenitis show dense particles in the acini, the salivary acini, that is mainly either viral particles or lysozymes. This condition is quite rare and the exact etiology remains unclear. Some authors believe that because of the close similarity of the condition with necrotizing sialometaplasia, in that both affect the palate more and causes necrosis of minor salivary glands, that the SANS is just a variant of the sialometaplasia. Other authorities believe that because a significant number of the reported cases of the SANS are in patients who had upper respiratory tract infections or live in either close quarters like military barracks, for example, or patients in histological examination have dense viral-like particles in their acini of the minor salivary glands, and that the incidence of the condition increases in the winter months, that it is possibly related to a viral etiology. In either cases, the prognosis of the condition is excellent. Its SANS is also a self-limiting disease with even a more rapid course than sialometaplasia, and all cases reported would resolve within 4 weeks or so. By this we come to the end of this presentation on the necrotizing sialometaplasia. Assalamu alaikum.